Heart disease is the leading cause of death in the United States. That's for both men and women. And while we often talk about prevention and treatment, not everyone faces the same risks or has the same access to care. Joining us now to talk more about this is Dr. Oyere Onuma. She is the director of the Massachusetts General Hospital Global Cardiovascular Health Program. Thank you so much for being with us.
Jessica, thank you so much for having me today.
It's an important conversation, right?
Yes.
So when you look across Massachusetts communities, what disparities to you stand out the most when it comes to heart health?
Yes, so heart disease, as you have mentioned, is the most common cause of death in the United States, in Massachusetts, and quite honestly, around the world. In Massachusetts, there are significant disparities in terms of the rates of heart disease or even heart disease risk factors like hypertension, diabetes, high cholesterol, depending on where you are. So depending on where you live, for instance, depending on socioeconomics, how much you make, depending on whether you live in an urban area or in a rural area. So these are factors that can significantly affect how people get heart disease and how they do even when they do have heart disease.
Absolutely.
For instance, if you think about, say, in the city of Boston, depending on what neighborhood you live in, there's a significant disparity for people who live, say, in the Back Bay compared to the rates of heart disease or hypertension if you're only a couple miles away in Roxbury or in Mattapan or in Dorchester. And these are factors that also then play into how many people are hospitalized with heart disease, again, depending very much on who they are, where they live, and where they grow.
Big difference in life expectancy just
Yes.
a couple streets away.
Yes.
And I know doctors at Mass General have launched heart health clinics really across the community. What differences have you seen since doing this kind of outreach to patients in their communities?
Yes. So, Jessica, taking this information and the knowledge that heart disease is so different depending on kind of what communities that you're in, we thought that it was important to close the gaps in terms of where people are and to take care from our academic medical center and into the communities where people are. For instance, we have a particular program, a research study called the Pressure Check Study that we've been doing that actually goes to churches and community health centers and barbershops and hair salons, screening people to see those who are hypertensive and to bring them into care with a particular focus on some of these communities that have some of the highest burden of hypertension. Our aim in doing this kind of a study is to do something that is more practical in terms of closing these gaps that we've talked about, and that in doing this, we can, over time, especially if we make this a key part of our system of care, we can over time decrease these differences in the rates of heart disease.
What have you been seeing so far when it comes to this kind of outreach from going in and doing that?
So what we've seen so far is that, we have had such a critical opportunity for education. We find that we're really kind of addressing an important gap in these communities around access to care, around basic education on what hypertension means, on what heart disease means, and also allowing numbers of people in these communities to access care in a lasting way. People are busy, they're working multiple jobs at a time. It is not always easy to leave, to take a full day off from work or responsibilities to go into the hospital. So by making that care more accessible, we're making it more likely that they receive what they need.
Which is huge, right?
Yes.
I know your work spans Boston neighborhoods, also communities around the world as well. What parallels, if any, have you seen from communities here to communities globally?
Yes. So there's such important parallels, when you talk about these disparities in cardiovascular care within our local communities here in Massachusetts, and even when you extend it beyond national communities here in the United States and look globally across the world. Heart disease is the most prevalent in a lot of low and middle income countries, even beyond kind of our high income setting here in the United States. Our program, for instance, the Global Cardiovascular Health Program, has been working with a very concentrated program in Cape Verde, which is an archipelago of 10 islands off the coast of West Africa. In Cape Verde, our work has really focused on understanding, these very significant gaps in heart disease care. For instance, there are about 700,000 people in Cape Verde, and for that population of people, there are only 5 cardiologists.
Wow.
And 5 of them who work part-time even in caring for that population. So our work really has been in trying to address some of these disparities in diseases that we know, like hypertension, high cholesterol, diabetes, but also in some types of diseases that we don't even see in a setting, like rheumatic heart disease, which affects young children in Cape Verde and other parts of the world.
And I know your big focus there is education, screening. Talk about why that's so important and what you've been able to impact so far since going into that community with 5 cardiologists for such a large population, and what are you hoping to achieve?
Yes. So I think a lot, big part of our work is really kind of enacting as a catalyst to improve care across the board. In the time that we've been working in Cape Verde, over the last 2 to 3 years, we've been able to increase the amount of equipment that they have.
Excellent.
Actually, we brought equipment in that they did not have at all. We've been able to galvanize the community in setting up a national screening program for rheumatic heart disease, really making sure that we don't have young children, pregnant women who are dying of something that is easily preventable using, for instance, an antibiotic like penicillin. We've brought a lot of awareness to the population and to the community. And we've also worked very closely with the government and the Ministry of Health in setting up a bigger plan that they can continue to run even when we're not physically there.
Right. That's huge. Amazing work that you're doing. We really appreciate what you're doing and for being here and shedding some light. Thank you so much.
Thank you.
All right. Well, seeing the ways your healthcare system can improve from multiple points of view, the author of The Collective Cure joins us when we return.